fourth webinar series, and they are extremely useful. Last month, we had a talk on vaccination in adolescents, and this month we have it in adolescent endocrinology, and such an apt topic. As pediatricians, we see so many adolescent children coming in with insulin resistance. Well, we'll go on to the topic later. But before that, I welcome all the dignitaries. I welcome Dr. Arun Sharma, sir, the ex-secretary, Central AHA, who is our chief guest for today. I welcome Dr. Chitra Kulkarni, ma'am, who is the chairperson, Maharashtra Adolescent Health Academy. And want to congratulate Dr. Chitra ma'am and the entire team of Jayant sir, Dr. Shailaja, Dr. Vaishali, Dr. Ram Bharat, Dr. Neha for the phenomenal job that you all are doing. I also welcome our guest of honor, Dr. Jitendra Gawane sir, and our expert today, Dr. Abhishek Kulkarni, for today's webinar. Over to you, Dr. Amog.
Thank you, Dr. Mangai. Now I invite the MAHA AHA chairperson, Dr. Chitra ma'am, to introduce our chief guest, Dr. R.N. Sharma sir.
Dr. Neha, will you please share the slide? Yeah, good evening all, and thank you very much for the kind words, Dr. Mangai. I am very much happy to introduce our chief guest, Dr. R.N. Sharma sir, a very humble and down-to-earth person in spite of his high achievements. His experience and expertise goes beyond 35 years, and he has been in important positions like EB member, Secretary IIP, President IIP Agra, and till date, he is still active. We are really very fortunate to have such a high-end person as our chief guest for an important seminar of Maharashtra AHA. Thank you very much. Over to Dr. Amok.
Thank you, ma'am. I would now like to request Dr. Sadachar to introduce introduce our guest of honor for today, Dr. Jitendra Gawane, sir. Dr. Sadachar?
Dr. Sadachar was present, no?
Mm-hmm.
Okay, Amog, you can introduce.
Yeah. So I would be honored to introduce Dr. Jitendra Gawane, sir, a well-known personality to all of us, who is a professor of pediatrics and PICU in charge of MGM Medical College, Navi Mumbai. And as of now, he's a joint national convener of the President Action Plan 2026, and he has been the ex-president of Navi Mumbai IIP. We welcome you, sir, and we would request you to just speak a few words.
Yeah. Thank you, Amok. First of all, thank you for giving me opportunity to be on this platform. Friends, we know that adolescent health chapter, as Mangai said, is always ahead of everything. Their module also is ahead of all other modules in the central IIP. Name also is ahead. And Maharashtra AHA is a driving force and a kind of branch which can be replicated or emulated by other branches. And this year also, Chitra madam is leading this from front. So congratulations, ma'am, and all the best for the next month's our Maharashtra AHA conference. Friends, adolescence period marks the period of profound physiological change driven by intricate interplay of the hormones, we all know. And this webinar deals with the complexities of these different hormones and adolescent endocrinology. Adolescent period brings significant metabolic shifts, increasing the risk of future cardiovascular diseases, diabetes, even in non-diabetic kids also. So let us learn from our expert, Dr. Abhishek, today, and we are lucky to have you, sir. Over to you, Amog, and all the best for the webinar.
Thank you so much, sir, for the kind words of encouragement. I would now like Dr. Mangai to introduce our speaker for today, Dr. Abhishek Kulkarni, and the topic.
Um, so today, like I said, is we will be talking on adolescent endocrinology, and the topic that we are going to cover is implication and management of insulin resistance in non-diabetic obese adolescents. So, and for this, we have a very renowned speaker. It's always a pleasure to hear Dr. Abhishek Kulkarni speak, and his vast knowledge and the depth of knowledge in endocrinology is immense. Today, we'll be hearing him speak on something. This will be obesity, like in non-diabetic. So that's also, I'm really looking forward to hear him speak on this. Dr. Kulkarni is a senior consultant, pediatric and adolescent endocrinologist, department head and postdoctoral fellowship program director in SRCC Children's Hospital, Mumbai, in Sir H.N. Reliance Foundation Hospital, Mumbai, and an honorary consultant at Apollo Hospital, Navi Mumbai. He's been conferred with the title of Honorary Adjunct Associate Professor and Distinct Clinical Tutor in recognition of his clinical, academic, and research contributions to the field of pediatric and adolescent endocrinology by AHERF India. He's also been awarded the Fellowship of Royal College of Child Health and Pediatrics, London. He's a member of numerous prestigious international consortiums. He's been invited faculty at more than 100 national and international forums. He has more than 25 indexed publications in renowned journals, and he has a keen interest in research. So let's hear over to you, Dr. Kulkarni, sir. We are really honored to have you here talk on this very important topic, because more and more in today's practice, we are seeing adolescents coming up with obesity or with some signs of acanthosis and other signs. And though we may know what to do, but many times we are in a fix on how to counsel or how to manage. So it will be really good to hear from you. Thank you so much, sir, for joining us today.
Thank you very much, Dr. Mangai. Am I audible or
Yes, sir.
Yeah.
Yes, sir.
Yeah. So I'd like to sensitize my pediatrician colleagues and obviously the pediatric endocrine fraternity. I always say that if you really want to make a change, you need to detect insulin insensitivity way before it translates into diabetes mellitus, because it is recognizable early, it's silent, and it's highly consequential. So the principle or the gist of the talk is to sensitize the pediatric fraternity on the implications and management of insulin insensitivity in non-diabetic obese children, particularly the adolescents today. So the Indian epidemic, 1 in 8 children in India are either overweight or obese. And it would be interesting to know that the newer definitions of obesity not just speak about the 23rd and the 27th kilogram per meter square adult equivalent, as we've been taught with in terms of the body mass index, but also speak of any excess or abnormal adipose tissue in the child. So just abnormally distributed visceral adiposity is also defined as being overweight or obesity. And it's very, very relevant to the subcontinent, because a significant number of our children and adolescents may actually not meet the BMI thresholds of percentiles or equivalents, but may be having visceral adiposity, putting them at risk of early metabolic syndrome. 30 to 40% of obese children end up depicting clinical signs of insulin insensitivity, and the prevalence of metabolic syndrome associated steatotic liver disease, the newer terminology for the earlier NASH, is present to the tune of almost 30% in the subcontinent. So the prevalence in the subcontinent is not just directly proportional to the adipose tissue distribution or the quantum of adipose tissue, but is also compounded by added underlying genetic predisposition, both polygenic and monogenic. So we are blessed or cursed with these added burdens in addition to the adiposity. So this is simple to understand that the prevalence of metabolic syndrome escalates with the severity of obesity. So if you're overweight, the prevalence of metabolic syndrome is to the tune of 6%. If you are obese, it is to the tune of nearly 30%. And if you're severely obese, by which I mean your body mass index is conventionally 120% above the 97th percentile, almost 50% of that population would depict one or more signs of metabolic syndrome. Now, what defines insulin resistance? It's physiologically decreased biologic response to normal levels of circulating insulin. And this is often masked by compensatory hyperinsulinemia or exaggerated insulin secretion. Now, we need to understand that the body compensates and normoglycemia is maintained through excessive insulin production. So insulin insensitivity is a metabolic risk state and not a standalone clinical diagnosis. And in adolescents, the physiologic insulin insensitivity during puberty often unmasks pathologic insulin resistance. Now let's understand hyperinsulinemia. Hyperinsulinemia is defined as fasting insulin levels above the 75th percentile for the ethnic specific population, the age and ethnic specific norms. Now, this is the biochemical definition of hyperinsulinemia and not insulin insensitivity. Insulin insensitivity is a metabolic state, while what I have defined here is just biochemical hyperinsulinemia. So we have norms for everything in pediatrics, and levels above the 75th centile, ethnic and age, sex, and ethnic specific are used to define hyperinsulinemia biochemically. Now, though this must not be used routinely in clinical practice, but its use be limited to clinical research and assessing response of pharmacotherapeutic measures, homeostatic model assessment is the primary clinical tool for biochemical evaluation of insulin insensitivity. So the formula is level of blood glucose in millimoles per liter into level of insulin in microunits per ml divided by 22.5. And if you want to look at Indian specific cutoffs, fasting levels typically of more than 17 microunits per ml and the homeostatic model assessment value of more than 3.95 would be defined as insulin insensitivity biochemically. Now, a caveat here is clinicians should not routinely use fasting insulin levels because a number of factors confound its estimation. First and foremost being insulin should be processed at the place where it is collected and must not be transported. The timing of collection is important. The way the sample is stored is important. And very, very importantly, biochemical assays used for measurement of levels of insulin are poorly reproducible. So a higher level only has a positive predictive value and the value may not be reproducible on a different date because a host of physiologic factors determine the level, and insulin levels do not maintain a steady state concentration in circulation at all points of time. Now, let me explain a bit of physiology from visceral adiposity to systemic inflammation. This is what drives obesity and insulin resistance. I often, as a pediatric endocrinologist at a tertiary care center, it's more biology-driven obesity that reaches us rather than behavior-driven obesity. The behavior-driven obesity is very well taken care of by our pediatrician colleagues. And what we end up seeing in the tertiary care setting is usually obesity, insulin insensitivity, and metabolic syndrome, where biology actually drives the adverse behavior and the metabolic deviation. So the first phenomenon to occur is excess visceral fat leads to a spillover of free fatty acids, which directly impair insulin signaling pathways in the skeletal muscle and hepatic tissues. Now, there is also an inflammatory cascade because of excess adipose mass that the cytokines, specifically TNF alpha and interleukin 6, are exaggerated in circulation, creating a pro inflammatory environment. South Asians, particularly, have a significant adipokine imbalance where there is decreased level of protective adiponectin and a pathologic increase in the levels of lectin and resistin levels. And ectopic fat deposition directly or mechanically leads to organ specific insulin resistance and metabolic dysfunction. So these are the pathophysiologic mechanisms through which obesity leads to insulin insensitivity, setting further the cascade of metabolic syndrome and also vascular endothelial dysfunction. So to repeat again, inflammatory cascade, adipokine imbalance, and ectopic fat deposition. Now, let's talk of its clinical implication. As clinicians, this is what is important to us, and it's very, very well understood that insulin resistance precedes type 2 diabetes mellitus often by years. But beyond glucose control, what is not often spoken about is dyslipidemia, typically high triglycerides, low value of HDL cholesterol, and increase in small dense LDL particles, exponentially increasing the cardiovascular risk. Metabolic dysfunction associated with steatotic liver disease, which is the commonest cause of liver disease currently in the Indian setting. Reproductive health, which is central to pediatric polycystic ovary disease, causing both hyperandrogenemia and ovulatory dysfunction. And very, very importantly, the genesis of adult life vascular disease is begun in childhood and adolescence with the advent of insulin insensitivity. And the most sensitive marker which could be detected is carotid intimal media thickness, which can be found out by doing sensitive carotid Dopplers. PCOS and metabolic syndrome associated steatotic liver disease are the bidirectional threat. Now, what hyperinsulinemia does is it directly stimulates ovarian theca cells to produce excess testosterone, bypassing the normal regulatory mechanisms. This is what drives hirsutism and acne in teenagers with polycystic ovary disease. The second important mechanism is insulin resistance also reduces hepatic production of the sex hormone binding globulin, increasing the biologically active free androgens, again worsening the clinical signs. And by corollary, this leads to ovulation dysfunction, which drives the pathophysiology of polycystic ovary disease further. What we need to understand is fatty liver or metabolic syndrome associated liver disease is caused by the double hit hypothesis. The first hypothesis is influx of free fatty acids, which promotes deposition of triglycerides in the liver, and the more sinister pathophysiology is hepatic insulin resistance stimulating de novo lipogenesis, which leads to a oxidative and a pro-inflammatory state predisposing the individual to fibrosis and liver cirrhosis. Now, this is something unique to us in the subcontinent, the thin fat phenotype hypothesis or the South Asian phenotype. And this is where we've made a suggestion to the Indian Academy of Pediatrics to revise the anthropometric criteria and include waist circumference as one of the most sensitive and simple tools which the pediatrician, even in the extreme periphery, could measure appropriately with a stretchable measuring tape. Because as individuals in the subcontinent, we have higher visceral body fat percentages at equivalent or lower BMIs compared to Caucasians. And this particular adipocyte distribution leads to lower levels of the insulin sensitizing adipokine, adiponectin, which is one of the aggravators of early life metabolic syndrome. And the important take home message here for my friends today is standard BMI cutoffs, if they are adhered to blindly without looking at the clinical phenotype and adipose tissue distribution in the adolescent, may easily underestimate the risk of ensuing metabolic syndrome. Now let's talk as pediatricians. We our science is incomplete without the knowledge of genetics, and it's one of the very coveted areas of research that I like to pursue. And what we've learned so far with our own research over the last 2.5 decades is predisposition in the subcontinent to obesity and metabolic syndrome. And I'm going to talk very briefly about genetic factors and epigenetic risk mechanisms involved. Now, 30 to 60% of all insulin resistance, at least in the subcontinent, and type 2 diabetes is heritable. And so, simple family history is a clue that with or without a higher BMI and deviant adipocyte distribution, the individual may be at a higher risk of insulin insensitivity and type 2 diabetes. And when we talk of gene variants, it is very important for the pediatrician to stratify them into single nucleotide polymorphisms, which are polygenic traits that we inherit from our parents, and single nucleotide variants, which is a more scientific term for the word mutations that we inherit or may develop de novo in utero. So the common variants that we have personally identified and published in very reputed international journals from the subcontinent are single nucleotide polymorphisms and variants in the FTO gene, the insulin resistance syndrome gene, the PPAR gene, and two other relevant genes which are the commonest in the subcontinent. Now, I'm going to talk of monogenic predisposition or monogenic etiology, but that's very, very rare and not the context of discussion tonight. But what the pediatrician must take home from the lecture is we must understand that 30 to 60% of all obesity, insulin resistance, and type 2 diabetes, at least in the subcontinent, is predisposed by gene variants, either polymorphisms or significant deviations in amino acid base pairs. And till date, close to 17 genes have been identified, of which the 5 commonest ones, which we have published from the subcontinent, I have highlighted here. Now, it also needs to be understood that the condition could be well programmed in fetal life in high-risk situations, particularly where there is maternal obesity and diabetes, intrauterine growth restriction, prematurity, and a rapid catch-up of growth in premature and small for gestation age individuals. So this cohort is inherently at a higher risk of developing insulin insensitivity due to epigenetic programming. Now, this is something which is interesting and I wanted to highlight, but must be kept at the back of the table and not as a first line thought. There are situations where you will see children who are extremely wasted with an abnormal distribution or lack of fat, but depicting significant acanthosis nigricans and often manifesting even with hyperglycemia. Now, if you see a picture like this, where a child is failing to thrive but depicts clinically significant acanthosis and almost manifests with hyperglycemia with or without syndromic manifestations, it's the situation where one would think of monogenic insulin resistance syndromes. And to simplify it, I have classified them into those involving the insulin receptors and those involving the post-receptor signal transduction. So this is something that the pediatrician must not miss, but is very, very rare in clinical practice. And these patients often depict values of insulin to the tune of 100 microunits per ml or above. And the syndromic ones typically are short, have intellectual disability of some form, and other organ malformations. And these patients, in contrary to being overweight or obese, will actually depict lack of subcutaneous adipose tissue. Now, screening in the outpatient. Now, let me emphasize again, is we do not recommend performance of fasting insulin levels by the pediatrician in the tier 2, tier 3 setting, only if the pediatrician has access to a processing unit and can get the sample collected and processed in the first batch after collection. Would it be permissible to collect a sample for fasting insulin levels? What should rather be emphasis laid upon is looking for clinical signs like acanthosis nigricans at the flexures, central adiposity, and increased waist circumference, which is very, very simple to identify, and plotting the waist circumference on percentile charts, and a simple history taking measure of family history of type 2 diabetes or metabolic syndrome, including fatty liver. Biochemical assessment, if you have to perform, you'd rather look at fasting lipids to assess if there is triglyceride elevation. Look at the SGPT to understand if the transaminases are showing an increasing trend, and the oral glucose tolerance test where you suspect dysglycemia to occur long before hyperglycemia sets in, and where the setting allows you to assessing the homeostatic model for assessment of insulin resistance by the formula that I mentioned about earlier would be permissible. Now, so coming to management of the condition, I have tried to simplify and stratify it under 3 headings. One is clinical or table share evaluation, which is simple body mass index estimation and standard deviation score calculation, waist circumference measurement, blood pressure measurement in the clinic. These must not be missed under any pretext. Then looking for signs of acanthosis nigricans as a proxy or surrogate for insulin resistance. Amongst laboratory workup, levels of SGPT, fasting glucose, and lipid profile, particularly the triglyceride, which has sensitivity in the early stages. Now, coming to management, lifestyle is the key, has to be long-standing, but often fails in isolation in the subcontinent because of an added underlying very, very strong genetic predisposition. But the take-home message again here is the mainstay of management revolves around lifestyle modifications, particularly those which are sustainable in the long run. And the principles to simplify are reducing refined carbohydrate consumption, sugary beverages, and prioritizing high fiber intake. Calorie restriction is suggested in settings where the BMI exceeds the thresholds of definitions of obesity, and restriction of calories is always performed in phases of 3 to 5% at a time and not more, and also very importantly based on existing dietary recall of the individual rather than trying to chase idealistic calorie diets. So we always ask nutritionists to assess a detailed dietary recall over the past 14 days, and where BMIs are exaggerated, we do recommend 3 to 5% calorie restriction, never more than 7% in the first phase, but always based on the existing dietary recalls, and never do we chase idealistic numbers. Protein adequacy must be maintained to support lean mass during the phase of weight reduction, and 60 minutes of moderate to vigorous structured physical activity daily is recommended. I'm going to talk a little bit on it as I move through the slides. Pharmacotherapy is indicated as an adjunct to lifestyle medication, to lifestyle modifications, and in the subcontinent, particularly in patients with exaggerated body mass indices or significant insulin insensitivity, and most importantly, in the presence of comorbidities, pharmacotherapy has a major role to play. Now, the management pillars, as I mentioned, are lifestyle intervention. It's the absolute cornerstone, but must focus on sustainable dietary changes and increased physical activity. The changes must be sustainable and reproducible for the adolescent to be adherent to them. Now, family-based models are successful as compared to targeting the child in isolation. Now, this is very easily understandable, and behavioral support is extremely crucial, like addressing psychological factors. A lot of adolescent obesity is driven or rather is exaggerated by adverse psychosocial environments. So pediatricians with interest in adolescent medicine would agree with me that there are often underlying psychological stressors which exaggerate underlying genetic predispositions and contribute to bad lifestyle routines. So addressing them is of paramount importance. Sleep hygiene, not just for good metabolism, but good endocrine regulation via the pineal gland axis and restriction of screen time are essential for long-term weight and insulin resistance management. Now, this is all very well known to pediatricians, is avoidance of skipping breakfast, traffic lighting of food substances, particularly segregating them by nutrient density to simplify healthy choices for patients and families, and the 5210 rule. It's very, very well known to pediatric colleagues, and I often see these boards placed in the waiting areas of pediatrician colleagues. Now, what is interesting to understand is endocrine societies now talk of leveraging exergames, which is a balance between exercise and video games. So this is something that endocrine societies are actively trying to work on, is in addition to the 60 minutes of moderate to vigorous physical activity that is recommended daily to meet the metabolic equivalents of tasks, video games recommendations are being made to companies to design video games which would leverage and include some amount of physical activity while playing games to bridge the gap between sedentary habits and physical activity, though this might be a very difficult task to accomplish in the near future. And as I mentioned earlier, ensuring age-appropriate sleep duration to support the endocrine balance and metabolic recovery are paramount. Now, let me talk a bit about it. Why the number of 60 minutes of moderate intensity structured exercises? So two important questions often asked is, Dr. Kulkarni, what is moderate intensity? So the simple message is when the kid is walking or running at a pace where he or she could speak in words but not sentences is moderate intensity structured or unstructured activity. And why 60 minutes? Because moderate intensity activity for 60 minutes a day corresponds to an expenditure of 9 to 1200 metabolic equivalents of task maneuvers per week. So this is the basis on which the number 60 minutes of moderate intensity structured or unstructured activity is derived from. And interventions ranked by their effectiveness in particularly reducing insulin insensitivity are combination of high intensity interval training and resistance training. And Amog's here and she'll concur with me the importance of strength training that has been incorporated in various research papers and guidelines now, in addition to high intensity interval training, because it has the best efficacy in counteracting the adverse profile of insulin insensitivity. Now let's come to pharmacotherapy. This is what we get to do a lot in our practice at the tertiary care center. But the take home from before I begin these slides is pharmacotherapy must always be used as adjunct to adequate lifestyle, adequate, optimal, and ongoing sustainable lifestyle measures. Pharmacotherapy is included when the adipocyte distribution is either grossly abnormal or the BMI cutoffs exceed the 95th or 97th percentile by 120%, or in presence of persistent and significant comorbidities. So the first line pharmacologic agent used in India is metformin for insulin insensitivity and impaired glucose tolerance. And how it works is primarily reducing hepatic gluconeogenesis and improves insulin sensitivity in the skeletal muscle and liver. Its impact is more pronounced on insulin resistance and glucose tolerance and modest for BMI alone. And hence, it is more of benefit in pre-diabetic states and pediatric obesity conditions where insulin resistance is pronounced. Not to forget, it is one of the mainstay therapies in adolescents with polycystic ovary disease because it addresses not just insulin insensitivity, but also the hyperandrogenemia that insulin excess drives indirectly. Now, this is something which is of interest to all of us, and these drugs are at least 5 to 7 times more potent as compared to metformin when we talk of efficacy in insulin insensitivity and for obesity. Even without insulin insensitivity or with insulin insensitivity, these drugs are almost 10 to 20 times more potent than metformin alone, and they too act via the AMP kinase pathway but have a host of other mechanisms, including transforming your white adipose tissue to brown and beige adipocytes, which are actually the storehouse of mitochondria which run thermogenesis. And hence, these drugs have the capability to increase the resting energy expenditure of obese individuals. Now, all of us who do research in adolescent endocrinology realize that the maximum number of calories are not spent on the sports field or in the gym, but they are spent at rest. So individuals who are blessed with a higher resting energy expenditure will have by corollary a leaner body type. And the GLP-1 receptor agonists are the only class of drugs which can transform white adipose tissue to beige and brown adipocytes, which have the capacity to increase resting energy expenditure. And just to give you an insight, the GLP-1 receptor agonist semaglutide, which has been approved for use in adolescents with severe and comorbid obesity, leads to a mean reduction of 16% in the body mass index over a duration of close to 68 weeks. The other drug that is often spoken about, which is tirzepatide, has dual action via the GLP-1 and the GIP pathway. And though it is approved only for use for type 2 diabetes as of yet in India, what we are seeing in the recently published SURPASS trials is it could lead to a reduction of 12.5% in the body weight in obese diabetic individuals. There are ongoing trials for its use in obese non-diabetic individuals, but currently in our country, tirzepatide is approved for use above 16 years of age in obese non-diabetic individuals, whereas semaglutide for the same population is approved for use above 12 years of age. Now, this is something I wanted all of you to see, the data from STEP-TEEN trials, which actually led to this drug being approved by the FDA. And this is a publication taken from New England Journal of Medicine. And you'll see the mean change in body mass index is close to 16% over a duration of 68 weeks with the use of semaglutide, which is once a week injectable preparation. And please look at the percentage of individuals who achieved respective weight losses of 5, 10, and 15%. Now, all the experts agree that a 10% reduction in body weight or a 12% or more reduction in BMI leads to significant improvements in waist circumference, glycemic markers, liver enzymes, and obviously by corollary cardiovascular health effects. So before I conclude, a quick word on what is on the anvil for future. Oral SGLT2 inhibitors, a class of drugs approved for use in the pediatric population for type 2 diabetes, have also found to show significant improvement in the level of liver enzymes, body mass indices, waist circumference without impacting the glycosylated hemoglobin or fasting glucose in the non-diabetic cohort. Now, this is interesting because they lead to significant improvement in the glycosylated hemoglobin in individuals with type 2 diabetes. And these drugs do not increase the risk of hypoglycemia because their primary modality of action is via the renal glycosuria pathway. And what has emanated from the ongoing phase 3 trials in non-diabetic obese individuals is they improve fatty liver metrics significantly. But currently, their position is limited to research, and prescription in the clinical setting is off-label and has to be exercised with caution. Now, key takeaways and summary before I conclude. Pediatricians must prioritize clinical findings over laboratory data. So, markers like acanthosis nigricans, waist circumference, and blood pressure measurement are non-negotiable. Please understand we Indians have the thin fat phenotype. So we need to remember that the standard BMI cutoffs underestimate the risk of adolescent metabolic syndrome and the higher metabolic vulnerability at comparatively lower body weight thresholds. Though extremely rare, screening for monogenic forms must be considered in thin individuals with insulin insensitivity and very obviously in cases where dysmorphism, lipoatrophy, and syndromic features are very, very explicit. Intensive lifestyle therapy remains the cornerstone, but in the subcontinent with a higher underlying genetic predisposition, appropriate use of pharmacotherapy where indicated is essentially the norm. These are the references from which the slides were prepared, and I thank you all for a very patient hearing.
Thank you, Dr. Abhishek. That was a very informative and exhaustive session. I had prepared a list of questions which have been answered in most of the slides because, like how you said, like early intervention and picking up the early flag signs are more important to prevent this pandemic. Still, we have a couple of questions. One was in the chat box. Yeah, so one question was, can we use C-peptide levels instead of insulin levels? I guess this question was by Dr. Agnimitra.
Yeah, so levels of C-peptide are currently limited to stratification of the diagnosis of diabetes mellitus because we do not have normative distribution data to correlate levels of C-peptide to insulin insensitivity. Though insulin and C-peptide are often released as a pair and very rightly thought of by the clinician here, as for diabetes, we often use C-peptide, measures of C-peptide to assess the beta cell function. The reason why we do not use it in obese adolescents or as a marker of insulin insensitivity is the lack of physiologic distribution or normative data. But yes, in times to come, when we do have normative data, the same could be used.
And one question was people with OSA, obstructive sleep apnea, they have a tendency to have insulin resistance. So can you just throw some light on this?
Yes, so it's actually the chicken and egg hypothesis here is obesity drives obstructive sleep apnea, and you'll often see in obesity clinics is unaddressed obstructive sleep apnea is one of the checklist boxes, which is a deterrence to losing weight while on therapy. So it is both ways, is adipocyte distribution in particularly in the neck and around is one of the key risk factors for occurrence of obstructive sleep apnea, and non-addressal of the same during therapy is one of the deterrences to reduction of body weight and also a median increase in the blood pressure centiles. So the dictum, at least followed in adolescent obesity practice is if the obstructive sleep apnea is significant, as stratified by the pulmonologist, it is addressed until the body mass index of the individual reaches a threshold where a repeat polysomnography is performed and the home CPAP therapy is taken off. So, short-term home CPAP therapy in morbidly obese adolescents is often the norm when we find that these individuals offer significant deterrence to ongoing pharmacotherapeutic and lifestyle measures.
There's another question in the chat box which I had myself is how long can we continue with pharmacotherapy? Because the myth which is there is once you stop the medication, the weight bounces back because adipose cells have a memory and then that
Yes.
weight loss comes back.
Yeah, so it's probably the billion-dollar question in the industry today, because if you read the newer publications, including as early as January in the Lancet 2026, researchers have categorically stated that therapy for obesity, particularly those driven by biologic mechanisms, must be accepted as akin to those of diabetes and hypertension. So, obesity now is increasingly being classified as a chronic relapsing multifactorial disease driven by genetics and or biology, and the therapy too must be as long as the biology persists. But if you ask us our experience, our own experience in the last decade since semaglutide, uh, initially liraglutide and then semaglutide has been available, is there is an entity called down regulation of underlying biologic pathways. So a significant number, a good 60% of patients who have been treated for a duration of 2 years or more with pharmacotherapy may have significant down regulation of the aberrant pathways. Now, in the South Asian population, it's typically the PPARG gene, the FTO gene, the insulin insensitivity, and the uncoupling protein 1. These four, for strange reasons, when treated with pharmacotherapy for a long duration, undergo significant bit of biologic down regulation. It is akin to caging a wild tiger for years and then hoping that the tiger has forgotten to hunt. So that is how I like to put it to my patients when they ask me that, am I going to be on it for life? Now, in South Asia, the American physicians are very categorical. And when they start semaglutide, they tell their patients that you might need to be on it on a small maintenance dose forever, like doses like 0.5 or 1 milligram. But here in India, neither the physician nor the patient accepts it currently for obesity without diabetes. If someone is already type 2 diabetic, it's still very easy to talk of long-term therapy to him or her. But if it's an obese, non-diabetic individual, the statistics, if you ask us our own data, good 60 to 70% of these patients will have significant down regulation. And if you want me to put up a percentage, they will probably gain back 30% of body mass index of what they have lost over a duration of 2 years. So over 52 and 52, 104 weeks of therapy, what we have seen is 60 to 70% achieve success. And if they have to gain back, they would gain back about 20 to 30% of what they've lost. And the phenomenon here is down regulation of the gene function. So you can't cure obesity, but with chronic hammering of the aberrant pathways, you can expect to downregulate them by good 60 to 70%. There's a paper on this in the Lancet this year in Jan, and it talks of this hypothesis, though a lot of it still needs better elucidation.
Yes, it comes down to lifestyle modification at the end of the day.
Yes.
Right.
I know you're a very big proponent of lifestyle measures, but I mean, I have a point of contention here is the type of population that you and I deal with. So you are dealing with much larger number of children where the proportion of behavioral abnormalities having triggered the obesity and metabolic dysfunction is higher, whereas all my friends would have screened and done what they had to, after which they will write a referral note to me. So the type of population that I'm going to see is the one where biology is driving the dysfunction, And it's the bad biology which doesn't allow the patient to adhere to lifestyle recommendations that you and I give, and also makes him or her crave for high glycemic index carbohydrates. So,
Yeah, that's a point well taken, Dr. Abhishek. I had one more question. Is puberty normally a physiologically insulin resistant state? Because we've known about this.
absolutely. And that's why, it makes a lot of sense an adolescent chapter talking about insulin insensitivity, because it's the time where insulin sensitivity is at its lowest. And that is why you'll often see that the borderline type 2 diabetics often decompensate during puberty. And why type 2? Even type 1s who have a limited beta cell reserve or latent autoimmune diabetes of the young would often decompensate when the physiologic insulin sensitivity is at its trough, which is typically puberty because of the high levels of sex steroids in circulation.
Yeah, we have Dr. Preeti Galgali with us, a very renowned adolescent expert from Bangalore, and I'm sure everybody knows about ma'am. So, ma'am has a few questions for us. What is the cause of acanthosis in IR? What
Yeah.
is the reason?
Yes. So as I mentioned during one of my earlier slides, is insulin resistance is a physiologic state of hyperinsulinemia. So normoglycemia is maintained at the cost of compensatory increase in insulin secretion, which then goes and occupies the IGF-1 and IGF-2 receptors, which leads to excess cell proliferation. And that is what leads to the velvety thickening at the flexures, because these are more densely clustered at the flexures. And that's why we advocate looking at the flexures while we are looking for signs of acanthosis.
Now, what is your opinion about waist to height ratio to measure IR?
Yes, obviously. So, in fact, the simpler tool that we have done now, waist to height, again, will need a lot of further delineation distribution. So, the simpler tool which Dr. Khadilkar's group had published a few years ago is just the waist circumference. And basically, what we are looking at is visceral fat distribution. And what we found is waist by hip ratio and waist circumference both correlated equally to adipocyte, visceral adipocyte distribution by DEXA scan analysis. So these patients were subjected to DEXA scans, and the visceral fat distribution was then correlated both with the cutoffs of waist circumference centiles and the waist for hip ratios. And the correlation coefficients were found to be near equal without a statistically significant difference between the two groups. And hence it was concurred that taking an appropriate waist circumference itself in the outpatient practice could be used as a sensitive marker for predisposition or risk to metabolic syndrome. Now, please understand, it is still not included by the Indian Academy of Pediatrics to define obesity or adiposity, but it is used to define at risk of metabolic syndrome, which essentially would mean the same, because the goal of all these anthropometric criteria is to screen and identify children who are at risk of metabolic syndrome.
Yes, and is acanthosis reversible?
Yes, absolutely. So these patients, when they lose 10 to 12% of their body mass, depict a good 70% reduction in acanthosis nigricans, except in the groups where the variants, the gene variants are highly penetrant, where loss of adipose tissue by itself may not be sufficient to reverse the clinical signs of acanthosis. And there the role of pharmacotherapy is immense, because their agents like metformin or GLP-1 receptor agonists help achieve us this goal, which is not doable by lifestyle alone.
Coming to GLP-1 receptors, do you screen for eating disorders before you start semaglutide?
Absolutely. And if you heard carefully, there was a slide where I mentioned that a lot of adolescents with obesity have underlying psychologic stressors. So as we ask for history in the outpatient, our postdocs often talk of comfort eating. It's a very easy way to connect to the adolescent instead of asking, offensive questions, it's very easy for us to ask that, my dear, do you often end up doing comfort eating, or do you resort to comfort eating? And they're very, very open to it, saying, yes, doc, every night, probably. So yes, history, very, very important. And one green light that I wanted to share is the American FDA recently cleared semaglutide for its association with suicidal ideation. There was a lot of talk in the news, in the media, though not in published journals, about association of GLP-1 receptor agonists with suicidal tendencies. Now, what I'd like to clarify is these drugs, via the hypothalamic nuclei, reduce the orexigenic peptides. Now, this is one of the key ways how they curb craving for high glycemic index foods. Now, you and I and every one of us here on the platform would agree that irrespective of our mood and how tired we are, food does make us happy. You go to a wedding, you go to a party, you are always going to be happy looking at the menu. And this is because of the orexigenic peptides secreted in the hypothalamus, which are affected via the various nuclei. Now, by occupation of these and by increase in the GABAergic neurons, neuronal activity, these drugs bring down the levels of orexigenic peptides, and hence a reduction in the mood score is well known while on GLP-1 receptor agonists, like it is for other neurotropic medications which act via the GABAergic activity. But these do not lead to suicidal ideation. So low mood, sitting alone and crying for a while are well reported while on therapy with GLP-1 receptor agonists, but cause and effect relationship has yet not been well established, because there are a host of other variables which impact mood in morbidly obese adolescents, body image issues being one of the most prevalent ones. So we've not yet been able to decipher whether it's the disease or the drug or a combination of both. But as you mentioned rightly, a questionnaire asking for history is mandated before initiation of therapy.
Is there any role of oral semaglutide as compared to injectable?
Yes, so in times to come, surely, but what we need to understand is the conventional doses of semaglutide of 3, 7, and 14 milligrams that are available in India for treatment of type 2 diabetes are currently not dose equivalent for treatment of obesity without diabetes. We are currently in a phase 3A for testing the oral formulation of semaglutide for equivalent efficacy. And what we find is a dose of 50 milligrams per day, which causes or is very, very intolerant to the gut, leads to a median weight reduction of 8 to 12% of BMI over 68 weeks in adolescents. But the median dose in the study is 50 milligrams. And anyone who's taken oral semaglutide for type 2 diabetes will tell you that he or she can't tolerate doses more than 7 or 14 milligrams if he or she is very, very determined, along with proton pump inhibitors and domperidone. So, we personally do not have experience of use of 50 milligrams outside the clinical trial setting as of yet. But the dose, if you ask me an equivalence, it's going to be 50 in a year or two to be coming around.
One last question from Dr. Preeti is, what is ominous octet, which you've mentioned in the slides?
Yes, absolutely. So we're digging deeper into physiology. Dr. Preeti, thank you for this. Is basically, in addition to escalating the resting energy expenditure, which is what drives their anti-obesity action and slowing of the gut motility. What these drugs, both the GLP-1 and the GLP-GIP dual agonists do is they augment beta cell function. So basically, in simpler terms, they delay progression from pre-diabetes to diabetes by reducing beta cell apoptosis. So that's one of the key components of the ominous octet is movement of the cells into apoptosis. So that is slowed by these group of drugs. Secondly, these drugs reduce or suppress glucagon secretion. And thirdly, very, very importantly, these drugs suppress de novo lipogenesis. So they independently of their effect on BMI can also reverse the fatty liver complex or the MASLD condition. So that is what the ominous octet is. This is the hidden secret of these drugs. And Dr. Preeti, I'm happy you brought it up. So these drugs have a host of benefits in addition to BMI alone.
Thank you so much, Dr. Abhishek. It was a rapid question answer round which you've taken so well. And the audience has definitely gained from today's session. If anybody else, Dr. Sharma, you want to ask anything, sir? You want to add your comments?
Yeah, sir, please unmute.
Thank you, Dr. Chitra ma'am and all team Navi Mumbai EH and IAP and all stalwarts of the IAP HA, office bearer of IAP and EHA. Thanks for giving me this opportunity. So all is covered by, well covered by Dr. Abhishek. Thank you, sir. Thank you for enlightening us for the very interesting and emerging field of insulin resistance in adolescent. Thank you for a very excellent talk. So just highlight few things. So the fasting insulin is important to measure. And family history, as Dr. Abhishek expressed, 30 to 60% family history is positive in diabetes. And all is well covered. The implications lead to diabetes mellitus, cardiovascular, metabolic syndrome, PCOS, non-alcoholic disease or liver disease. And one important thing I would like to stress, psychological impact of this is also important for adolescents, like low self-esteem, depression, and body image issues. Management, well discussed. Balanced diet, physical activities, 1 hour daily, and sleep is also an important factor in this. 8 to 10 hours sleep for adolescent is must. And limitation of screen, less than 2 hours. In this era, digital era is also important. And in my opinion, Dr. Abhishek is also same. The pharmacotherapy should be kept in the last option. No medication and drug for this. And one more important, as I feel in my life, everybody, adolescent or adults, your body give indication to you, to your mind, that there is something bad in the body. We miss this just like a satiety center. We miss this indication or ignore that indication. That lead to the diseases of the modern diseases of the life. So in the last, I would like to say, listen, just we advocates, parents, listen to your child, listen to your child, listen to your child. I just want to say, listen to your body. Listen to your body. Listen to your body. And you will come over all the problems, physical and mental. Thank you. Thank you very much for giving me this.
Thank you, sir. It's a family-based intervention at the end of the day. Dr. Chitra ma'am, do you want to add a few comments?
Yeah, like most of our colleagues from US, they say that yes, we use the injectable drugs very often because we cannot control the lifestyle. I want your opinion, Dr. Abhishek, on that.
Yeah, so as mentioned previously, rather than looking at, I have a policy which a lesson I've learned over the last 2 decades in practice is, and also now it is being increasingly published, is we look at adolescents with obesity in terms of the etiology rather than the quantum of the weight or the adiposity that they possess. So a large part of our time is spent initially in stratifying the etiologic basis of obesity. If we find that it is predominantly the lifestyle component, then unless there are presence of comorbidities, we like to reserve the drugs for a later date. Now, presence of comorbidities leads to early action because these comorbidities can cause significant hazards, and as adolescent experts you'll realize they follow the principle of tracking. So if you don't hit them hard in adolescence, they're going to track into adulthood and be there forever. So presence of comorbidities is an immediate indication for pharmacotherapy. Otherwise, what I personally like to do, and is usually now the published norm, is stratify the obesity based on etiology and its extent. So class 2 obesity with comorbidities or class 3 obesity even without comorbidities becomes an indication for pharmacotherapy. But class 1 obesity without comorbidities, this is what the pediatrician is commonly going to see. And the role here is to understand what is the biology driving. Is it biology or is it behavior that is predominantly driving the obesity? So if you have an underlying genetic and or epigenetic mechanism which has triggered or aggravated obesity, there is a definite tilt towards pharmacotherapy, because in these conditions lifestyle alone, even though is the mainstay, is often unsuccessful. And if you ask me percentages, most researchers have published numbers of close to 60%, saying 2/3 of all of these obesities will relapse chronically on lifestyle measures alone, because these individuals have a disease. Whereas where behavior is driving the biology, lifestyle measures alone in the absence of comorbidities suffice. But what happens when you're making an advocacy is you cannot make a random or an empiric advocacy for pharmacotherapy. So across fora, you will hear people talking of lifestyle measures as the mainstay. But as we dig deeper, it's the extent and the underlying etiopathogenesis that decides as to who is going to need pharmacotherapy early in the course of treatment of the illness.
So how long to wait? Like for 1-2 years, or we have to
So the
categorize and start?
So the guideline in class 2 obesities and class 3 obesities is to start treatment early. Class 2, if there is presence of comorbidities, then you do not wait. But in class 1 and class 2 without comorbidities, the dictum is to wait until 12 months, provided you are achieving a reduction in body mass index of at least 4% every 4 to 6 months. So if you're achieving a reduction in body mass index of up to 8% in a year, you are allowed to wait, and that too in the absence of underlying significant genetic and or epigenetic predisposition. If you're dealing with an infant of diabetic mother who's now an adolescent with PCOS, I don't think it is a wise strategy to wait any moment in this individual. So it's the holistic picture and the background of the individual that decides who is going to be initiated on pharmacotherapy sooner or later.
Perfect. Thank you.
Okay.
Thank you so much, ma'am. Dr. Mangai, you want to add anything?
No, it was an excellent eye-opening talk. And all the comments that have come from everyone are also significant. I think what I would add here is, as pediatricians, the onus of identifying these children lies on us. But the therapy or the treatment or the management is more of a teamwork, where even adolescents experts come into the picture to handle the mental health of the child and to motivate the child, and then experts like Dr. Kulkarni come into the picture to handle the drugs and the other indications and management. So it's a full teamwork. That is what we can gather, and a very important issue. So I think we should all be up to date with it. And excellent lecture. Really thank you to the Maharashtra Adolescent chapter to take up such topics, and wonderful, Dr. Abhishek, as usual.
Thank you, Lord.
Dr. Preeti, would you like to add something?
Preeti ma'am? Preeti madam? Yeah.
No, thank you. Thank you so much. Thanks, Abhishek, for answering all my questions. It's been a pleasure listening to you. Thank you and good night.
Thank you.
The best part is all the misconceptions and the indications of the drugs were cleared well today, because there are so many discussions on different forums, especially on social media and even in the medical fraternity, about the side effects of these drugs. So we got a very clear picture today and we've understood the indications. Thank you so much, Dr. Abhishek, for being so patient and answering all our questions, even though it's 15 minutes past 10. So now I would like to invite Dr. Vaishali Shetty ma'am, the Secretary of MAHA AHA, to give the official vote of thanks.
Yeah, thank you, Amok. I'm very much thankful to all the audience because that is the most important thing. And the one important thing I would like to highlight over here that Dr. Kulkarni has said, prevention begins with understanding and reversal begins with action. So that was the take-home message, and that was very wonderful. I'm very much thankful to Dr. Sharma as he told us regarding that we should listen to your body, because the body gives you signal all the time and we should understand what are the signals and you should react accordingly. I'm thankful to Dr. Mangai also, Dr. Preeti Galgali madam, and those who are present on Zoom platform. So thankful to all of them. And actually we should stay connected with each other, because after all it's a teamwork, and we should do something good for the adolescents by early understanding and changing their lifestyle management. So thank you so much and good night.
Good night, everyone.
Thank you.
Thank
Thank
you.
you.
Ma'am,
Good night.
before
Fantastic
we sign off,
talk.
I would like to announce
Thank
that
you,
the next.
Abhishek, and thank you, Kulkarni madam. Thank you, Amok.
Sir, just a minute, sir. We
Excellent.
have the next session coming up next month in April, which is going to be taken by Nasik AHA, and we have with us Dr. Deepashri Tatar, who is going to be giving us a little bit of information about the same. Dr.
As
Deepashri?
well as Dr. Sadachar is also there. Both
Yes,
the
yes.
candidates
Dr.
from
Sadachar is there.
Nasik
Right.
city branch
Just-
are here. Yeah.
Thanks a lot. This was excellent talk, Dr. Abhishek sir. It was really eye-opening. Just an announcement that next month we are going to have a talk on the high-risk behaviors in adolescents and how to deal with it with various strategies and interventions. So please remain in contact with us and do join next time. Thank you.
Yeah, one more thing, sir. I have already posted on the group that all of you should fill the Google Sheet regarding your city branches, who are the presidents, treasurers, as well as the secretary. Please fill that Google Sheet properly, because we have to send it to AHA, Central AHA, by tomorrow. So I'm requesting all of you, those who are present over here, even on the group also. So thank you so much.
Yes. Dr. Deepashri, you want to share something about the next coming up webinar? It's okay. She's not available probably. Over to Dr. Amok.
Yeah, thank you everyone for a patient hearing, and especially to Dr. Abhishek for sitting with us till the end. Thank you so much. We're really delighted and we're very grateful for your time and efforts. Thank you so much. Good night, everyone.
Thank you for the opportunity.
Night. Bye-bye.
Good night.
Shall I end the meeting? Thank you, sir. Thank you so much.